palpable pedal pulses bilaterally. The ankle brachial index is 0.9 and 0.9 on the right and left, respectively. The most likely diagnosis is
okay. Before we go that, let's go through that question. Okay. So what do you think she had? This patient, she has a cramping after she walked 250 and resolved after 3 minutes. Okay.
Okay.
So it's like typical for vascular claudication, right?
That's true.
They give you a risk factor like hypertension, walking. Okay. I'll give you that she has a risk factor for sclerosis. No, it's too much noise. All right, but the problem is ABI is normal. So what do you think? Do you still think we have vascular claudication, or do you think that we are dealing with a neurogenic claudications?
The risk factors are there for vascular, but the ankle brachial index does not go with it.
Right. So what we do in this situation? If we think the patient has a vascular, but the test is not going with that, you know, and she has pulses, pedal pulses. So how we can unmask it? Because you think it's a vascular, all of a sudden you go to vascular, but you examine the patient, she has good pulses, PI is normal. Then what we do? We put it on treadmill, right? This is the reason why we have a treadmill. Because sometimes you have a mild to moderate stenosis, you cannot on rest, you cannot, you know, you cannot find it. The reason why you put them on a treadmill and let them exercise to the point they get the pain, then you do an ABI. Then you can see make significant drop in the ABI. So if you have a doubt from the history that is a vascular, but your exam doesn't go with that, then you put the patient on the treadmill, and you do EBI before at rest and after exercise. If you don't see any change, then 400% is not a vascular, then neurogenic. But if you see significant drop, then this is vascular claudication, okay?
Okay.
So let's go with that. Spinal stenosis, we don't think so because history doesn't go with it. It goes with when he walked and resolve after resting. So it's classic for vascular claudication, correct?
Sure.
High-grade stenosis, you can read it, go ahead.
High-grade stenosis of the right iliofemoral and femoral popliteal segments, or multi-level disease on the right, and the location of which cannot be determined with this information.
Well, let's go one by one. Let's go one by one. You know, okay. Patient has a pedal pulse, correct?
Yep.
So, and you still think he has a stenosis, okay? Does that mean this stenosis is mild or moderate? And possibly is very high because when you have a stenosis or occlusion distal, then you're going to lose the pulses. The more you have a stenosis proximal, you can still have a pulses. Like sometimes you have patients with complete aortic occlusion if it's chronic, and you can still get like a good pulses, you know. So the higher is the occlusion, you still can get the pulses. But the more you go distal, you lose the pulses. You know?
Okay.
So if you have a pulse in the iliofemoral, and femoral, and second thing, when you have a pulses, that means the occlusion is moderate to mild. It's not like severe stenosis. So it can be in multiple levels. It cannot be distal, you know. So most of it would be like all mild to moderate, something very proximal. Okay.
Okay.
So we go second one, high-grade stenosis of right iliofemoral and femoral popliteal segment. No, if you have this occlusion or stenosis, then you're going to lose your pulses. No way you can have a pulse with this occlusion. So next one.
Multi-level disease on the right. The location cannot be determined with this information.
Also, it cannot be right because multiple level disease, it can. You're going to lose a pulse if you have multiple level. If you have like SFA, popliteal, no, we can still have a pulse. So it could not, this is wrong.
Or isolated right SFA occlusion.
Also, you cannot get a pulse. Lose it. You are now more distal.
Or then this is proximal iliac artery, which is E.
E. So the most probably is a stenosis at the right common iliac. It's very proximal. Even external, you can't get a pulse. You're going to lose a pulse. So it has to be at the level of the aorta or common iliac artery. It has to be mild to moderate stenosis to get these features. Okay, it can be at this level. All right. Well, let's go to next one. We go back to who else was asked? Who want to participate?
محمد العبود بغيت عارف دكتور.
Hamad. Yeah, go ahead, Hamad.
Yes, sir.
Let me find the question. 13. This is we finish. Here, 14. Okay.
It looks a fatty question anyway.
Fatty question? No, sometimes too long. Simple answer. Question is simple.
A 75-year-old woman presents to clinic with 1 year of worsening pain in both legs with walking. She describes pain that radiates from her buttocks into her calves and feet after 5 minutes of ambulation. She describes relief when she stops walking and rests. So this goes mostly with a chronic picture of vascular claudication, or?
Okay, that's correct. Yes, because it's been going for a year. It's not a sudden. It related to her buttocks and her calf after walking, and is relieved by rest. So it looks classic for vascular. Okay.
Nice.
So let's see what happened.
On examination, she has normal pedal pulses bilaterally, and the diagnostic test that would best differentiate vasculogenic claudication from pseudo claudication due to a neurogenic source is okay. A bilateral
before, you see. So what they tell you here exactly like as the question before. So what happened here is the same. You have patients with claudication, and they have normal pulses, you know.
I see.
So you are not sure, is this a claudication or maybe like, you know, pseudo claudication, maybe neurogenic, even though the picture goes more neovascular. So you need something to help you to make a diagnosis, you know.
I see.
So if you do an EBI, it may come back a normal like the other patient. So you have to do something more, you know. So let's go one by one.
So first, bilateral lower extremity arterial duplex.
You see, this one, it may not unmask it because when she's rest, the EBI will be fine because she doesn't have a moderate, mild, severe stenosis. So EBI could be a normal. Even the vascular, you know, is not significant stenosis. So you may not see change in the arterial duplex, you know. So but arterial duplex will not help you here. It helps you if you have like no pulses, you have a significant stenosis, you know. But in patient like a borderline, sometimes the lower extremity could be back to normal, you know.
Yes.
So the second options.
The second option is ankle brachial indices obtained at rest and following exercise.
Okay. So this is what we talked about before. So you do at the rest, and then you want to trigger the patient's symptoms. You put him on the treadmill and exercise. Then you measure the EBI. So at that time, if you see significant drop, then yes, it's a neurogenic. So you need to unmask it, you know.
I see.
If you do an exercise treadmill and it's still the EBI normal, then 400% is not vascular. So that's exactly what we do. So if you have a doubt, then we go with a treadmill exercise. Okay.
Okay.
Next one, CT.
CT angiogram of abdomen, pelvis, bilateral lower extremities.
See, this test, it can give you a stenosis, right? It can show you where's the stenosis. So this should be the answer also, right? But why this wrong? Because it doesn't give you a physiological evaluation. Like it doesn't mean every time you have a stenosis, that symptom coming from there, right? So the CT, it may show you stenosis, but maybe it's asymptomatic. Maybe symptoms still for neurogenic, you know? So CT will not help you here to differentiate. It can show you the blockage, but how we can tell this is his symptom from there or not? You see, this is the reason why this even looks like a right answer, but it's not. CT angiogram will not help you because the same if you do like MRI of the spine, because the spine may show you like he has a disc, but how would I know this disc is responsible for his symptoms? You see, so you need something more physiological test, which is EBI during exercise. Okay.
Okay. Okay.
So this is PC and D the same. E
is diagnostic aortogram, pelvic angiogram, and lower extremity runoff.
This also would not help. Some people they measure the gradient if you see stenosis, see if significant or not. But the prime, remember again, when you do the angiogram, patient rests on the table. So you may not see this gradient. Some people, we used to give a vasodilator to just dilate the artery distal and see if we see a gradient. But again, these days with a CT angiogram, with an EBI, with a treadmill, rarely we do diagnostic angiogram. So this will not be also one of our choice. So I think the best choice in this condition to send the patient for treadmill tests.
Very clear.
Okay. All right. Let me see if anybody else here with us want to. No, I think Muhammad, I have to go back to you. Okay, Muhammad.
Yes.
Let's go back to questions 15. Okay.
Okay, doctor. A 20-year-old college gymnast presented with worsening left calf pain and foot paresthesia after exercise. The physical examination finding that may help diagnose her pathology is.
So let's go first. So she's
Yeah.
21 years old.
Yeah.
After exercise, what her symptom? What is what she has?
She had worsening left calf pain and foot paresthesia. I think in this age they want us to think about popliteal entrapment syndrome, most likely, and followed by external iliac compression with the gymnast and the cyclist. But I think this goes more with popliteal and artery entrapment. So look for that.
What other things you said? What is the other one you said?
The other thing with the external iliac fibrosis comes with the cyclist, with the bending.
Yeah, but you see, external iliac could give you a symptom more in the thigh, not in the calf.
Yeah.
So you need to more distal.
Yeah. The first impression is popliteal artery entrapment. So I'll look for
artery entrapment syndrome. Correct. You remember what the pathology, what the muscle? I think they have it here. Happen gastrocnemius muscle.
The medial head of the gastrocnemius muscle. Yeah, you have to remove it. So A, absent of medial pulses at the wrist.
No.
No. B, reproducible pain with deep palpation of the left gastrocnemius muscle.
No, why should there be?
No, it will not have pain. Yeah, no. This is mainly on that. Yeah, C, loss of medial pulse with dorsiflexion or plantar flexion of the foot. Yes.
Yeah, I think this is a test. This is a typical test.
This is the typical test.
It's like the same when you do thoracic outlet syndrome, you know?
Yeah.
It's positional. It doesn't happen all exercise. So you have to imitate the exercise. So you ask the patient to do dorsiflexion or plantarflexion.
Yeah, and you check for
then you can see if it's a pulse, you lose a pulse. And this is diagnostic, you know, with the history, of course, you know. Next one.
D, varicose vein of the calf on the thigh, and E is absent of left femoral pulses.
No, they don't.
I think, yeah, E is with more with external iliac fibrosis.
Yes. This one mostly go with a loss of pedal pulses, you know.
Yeah.
So they want just to think about entrapment syndrome. And the treatment is, of course, surgery, right?
It's surgery, yeah. You have to
endovascular for entrapment syndrome.
Yeah, you have to cut the medial head of gastrocnemius and you move it.
The medial head, yes. All right. I think here she's just showing a picture before and after. You see, after you do dorsiflexion, this is not a diagnostic, but I'm just showed to you how you can, you know, it's a compression. But you don't do this test, you know. All right, let's go to 16. We'll go to Sam.
A 55-year-old male smoker with hypertension and hypercholesteremia presents with left lower extremity claudication after walking for a half mile, which is not lifestyle limiting. His ankle brachial index is 0.7. Assuming successful smoking cessation and adherence to risk factor modification, including antiplatelet and cholesterol-lowering medication, statin, the chance that he will develop increased disability warranting intervention over his lifetime is. So we are talking about the ABI.
So what they want to ask you here, but Sam, they want to know what the natural history of claudication. Like if patients are claudication, we follow them for like 5 years. What happened? What happens? The majority is, so patient with a claudication, they are benign or is a malignant course?
Depends on the ABI findings. If it is mild claudication, mild peripheral vascular disease, moderate or severe. So from 0.7 to 0.9, we consider it as mild peripheral vascular disease.
Right. So when patient comes with claudications, okay, that means most of the is mild to moderate. Because if you go down like 0.5, then we can talk about critical limb ischemia or risk. So I'm talking patient with a claudication. Patient come to you, say the same, like here, I walk like 100 meters, 200 meters, to go with a rest or with a pain. So you decide to do consultative management on these people. Because we know that claudication, that is why we don't push patient for intervention, because we know that the course of claudication is a benign. If you follow up patients for 5 years, the majority, 50%, half of them will stay the same. They don't get worse. 25% get better, and only quarter they get worse. They may end with a critical limb ischemia. And very few, less than 10%, they end with tissue loss or amputation. So this is a number. So what they want to tell you here, they say, just want to emphasize that don't be aggressive with the claudication, because the history of patient with a claudication, most of the time he will stay the same or get better. Only about 25% they get worse. So why we have to treat 75% for the sake of 25%? Doesn't make sense. So what he's going to say here, what the percentage will develop disability required intervention over the lifetime, had to lifetime, not 5 years. He's 35 years, but had to in a lifetime. So how many percentage of them?
Yeah, as you mentioned, it's 25. So 50% will improve, 25 will deteriorate,
and 25
will end with critical limb ischemia.
So the reason why 25% is not much. The reason why we're not very aggressive with them. Okay. Ahmed, can we see Ahmed?
Yeah,
Ahmed,
I can
take this question.
Okay, 72-year-old woman. She presents with bilateral calf claudication, which is noticed only when she takes long walks. She has successfully quit smoking since her last clinic visit and is on aspirin and statin regimen. She hasn't experienced any significant symptomatic improvement with 3 months structured exercise therapy. A CT arteriogram indicates transatlantic the task A lesion in the right side, superficial femoral artery, and task B type lesion in the left SFA. Task A in the right side, superficial femoral, and B in left SFA. The most appropriate treatment is?
Before we go that, Ahmed, so let's talk. She's 72 years old, okay? And she has claudication, claudication. But see what happened. She quit smoking. She's an aspirin statin, and she improved. They said she has not experienced any significant symptoms. She did not improve. She has not experienced any significant symptom improvement within 3 months of structured exercise therapy. Okay? So she did not improve after 3 months. CT showed type A lesion in the right and task B lesion on the left. Okay.
Okay.
And know what she said. She noticed only when she take a long walk. Okay.
Okay.
So that means we're not having no wrist pain, This is not a short distance like 100 meters. It's about when she walked a long time. So she did whatever she did, aspirin, statins, but she not improved. So the question now, should we do intervention or just continue medical treatment?
She was given the treatment and a
Right.
smoking cessation,
But
and yet
remember
she did not
what we said
improve.
before, when we talk about before, you just mentioned that claudication, 50% will not improve, but they not get worse.
Yes.
So, and if it's not life limiting, it's okay. They can live with that because that intervention is not the best option for these people, So that's why patient comes to our clinic. If he's walking fine, I mean, yes, he still have a pain, not improving, but it's not getting worse. There's no tissue loss. He still can walk like 200, 300 meters, 2-3 blocks. It's okay because we know that half of them will not improve. Only quarter will improve, but only quarter will get worse. So don't jump to the treatment. That's what they tell you. Don't jump for the treatment. Even they're not get improved, as far as not getting worse, this is good. So when they come to me after like 3 months, I ask him, are you feeling better, worse, or same? He tell me same or better, I'm fine. The only time I get worried if his symptom get worse. Okay? Then I have to change my plan. But as far as he tell you I feel the same or better, then don't change your plan. So let's go back what they said here.
Task Class A disease should be treated open based on strong evidence. I think it's
Task A disease should be treated open based on strong evidence. Okay, let's continue. Task B.
Task B class disease should be treated endovascular based on strong evidence.
Okay. Really, I mean, this one, first, we're not going to treat it. Let's just tell you how we're going to this question. First, class A, we know that task A, usually it's endovascular.
Yes, B is surgical.
B, it's really not. B and C is controversial. B is surgery. B and C is still controversial. Some people, they said endovascular, some people say surgery. So we not. So first, A is surgery, is wrong. B, they said endovascular, based on strong evidence, no, we don't know yet. So B and C is still like a gray line. So this is wrong. But even if his answer was correct, I will not do anything for him. So this is not my plan. I'm just tell you this one, even this one is wrong. Because it's not endovascular based on the strong evidence. This is wrong.
Yes.
Let's go next one.
Open revascularization is superior for those patients with 5-year life expectancy based on the Basel trial.
Okay, let me talk about Basel. You don't know Basel trial because this is, for yourself first here. Basel trial is a trial where they compare bypass versus angioplasty. But this is for severe ischemic or critical limb ischemia, not for claudications, okay? So Basel trial only for critical limb ischemia. So to put it here, it's wrong because we talk about claudication, okay?
Claudication, yeah.
So this is wrong because Basel trial nothing to do with claudication. It's mainly critical limb ischemia. So this is also wrong. Okay, let's next one.
Wrong.
Let's go next one, D.
D is wrong because the patient is not a limb-threatening ischemia.
Correct.
She has medication.
Correct.
And E is the most appropriate one, as 50% of them will improve, at least not deteriorate.
Right. So no further intervention is required. She doesn't feel her lifestyle is significant limit. Of course, if patient is like athletics and he's limiting his lifestyle, is different, And even these ones, you have to be careful. If you decide to treat them, you have to treat like a lesion which have a long chain, because when you are claudication, it's different from critical limb ischemia. So if I decide to treat a lesion for claudication, I have to have a long-term patency. Like if it's a occlusion, I will not do it for claudication because I know the patency is very poor. But like localized common iliac artery stenosis or occlusions, it's worth it to do it for claudication if he has a lifestyle limitations, because I know the patency for common iliac is very good. You see, there's a way also you have to look for that. Where is the lesion and what is the long patency? So when you talk about claudication, you're looking for long-term patency. So most of it you're going to be working on aorta iliac level. but don't do anything for SFA, popliteal below the knee for claudication because they don't stay open for a long time. They are useless. All right. All right. Let's go to the next one. Go to Muhammad, our cardiac surgery fellows. Here we are.
So a 58-year-old man presents with buttock and calf pain with short distance ambulation, less than 50 meters. His past medical history includes active tobacco use, 1 pack per day, hypercholesterolemia, coronary artery disease, myocardial infarction, diabetes, and hypertension. On examination, he has no palpable femoral pulses. Upon further questioning, he complains of the inability to obtain an erection. The most likely cause of the sexual dysfunction is.
So you see, Muhammad, it's a fat question, but it's an easy answer, correct?
Yes.
Yeah, I mean, just tell you a patient has no femoral pulse and has sexual dysfunction. So where's the blockage has to be?
It's a proximal blockage.
So muscle in the aorta or iliac, right? Because
Right.
before the internal iliac. So let's see what they said. Number 1.
Is microvascular disease wrong?
No.
B is neurogenic dysfunction. Also no. C, diminished testosterone levels. No. D, psychogenic causes. No. We end with E as aortoiliac occlusion, which is most likely answer.
Yeah, it's a straightforward question. Really. Not much to talk about it. You know, it's an easy question. All right, we'll go back to Muhammad Tahman. Well, let's get 19. See, some question really simple.
Yeah. 19 is a 70 years old woman with a history of heavy tobacco use and metastatic lung cancer, present with 2 weeks history of worsening pain in her right foot. She had stable exertional calf pain for several years, but recently noted acute pain in the toes of her right foot at night. She had palpable femoral pulses, but only Doppler signal in her pedal vessels. Her foot is erythematous and warm when dependent. The most appropriate next management is.
Okay, well, let's start first one by one. She's 70 years old woman. She's small. But she has metastatic lung cancer. Okay. Yeah. So that means prognosis is not great. She's an old lady. But she has history of worsening pain in the right foot for 2 weeks.
Yeah.
So it's like more acute and chronic, right?
Yeah, acute on top of chronic with a wrist pain now.
Right, because she has still double signal, so not an acute ischemia. She has double signal in her pedal. And her foot is erythematous and warm when dependent. So you have dependent rubora, right?
Yeah.
So we like critical limb ischemia. So 74 years old, metastatic lung cancer, come with a critical limb ischemia. So you have to so the only options you have is 2. You're going to do a surgery or you're going to do an angioplasty and interventions. This is mainly will be your choices, right?
Yes.
You have to do something. She's a severe pain, you know, she has dependence, she has critical limb ischemia. So what do you think is the best option for her?
Yeah, for me, I have to start with angio, to be honest.
Okay, this is good answer.
Before surgery, because she's 2 weeks already, and she had acute on top of chronic, so most likely thrombosed on top of calcified vessels already.
You see, when you have acute and chronic, there's no place for thrombectomy because it's not like a vessel artery you can do thrombectomy.
Yeah.
So anytime comes acute on a chronic, either we're going to end with interventions or do a bypass. You cannot just do thrombectomy. Thrombectomy only for healthy artery, like patients normal and he get like AFib and get a clot, you know. And this is the reason why when patients are healthy and come with acute limb ischemia, I don't need to get a CT angiogram. If he has no femoral pulse, that's it. I know he has a good clot here, and I know his rest of the artery is normal. So I take him right away for, for open thrombectomy or thrombolysis without CT. When patient comes with acute on chronic, then no, I want to do CT angiogram. I want to see how this cell vessel, because most of it I'm going to end with a bypass. It's not a simple thrombectomy. So I want to see how is my distal runoff,
Yeah.
Anyway, so we go back to this question. When patient has critical limb ischemia, then we have to do something. We have one of two options, as intervention or bypass, And this could take us back to the drill, to the, what's the name? Yeah, we talk about it. Drill basal
trial.
Which we talk about. They compared angioplasty with a bypass. Of course, the bypass is much better. The first 2 years was no different, really. After 2 years, the bypass patient did much better regarding mortality and everything. So what they come with a recommendation that if patient survival rate is more than 2 years, then patient with critical limb ischemia, you need to do a bypass.
Yeah.
If it's less than 2 years, then do intervention. This is a recommendation from Basel trial, And because we know intervention doesn't have a long term, and this patient's critical limb ischemia, 50% was end with amputation. So it's a serious, It's different from claudication. See, claudication, 25% get worse, but when you have critical limb ischemia, usually within a year, 50% end with amputation. So you have to be aggressive with them, And most of the time, if they have a long-term survival, it's better to go and proceed with a bypass, This is a recommendation. But this patient, she has metastatic lung cancer. She's 74 years old. So I don't think I'm going to do a bypass for her for 5 hours. I don't think she will survive even 1 year, with a special lung cancer,
Yeah.
So if I want to do anything, most of it, I just do some angioplasty, just get her relief temporary until whatever left in her life to live comfortable,
Yeah.
All right, let's see what options.
Yeah. A is smoking cessation and exercise therapy. I think we eliminated this. B, pain control and antibiotic. C, CT angiogram to evaluate for tibial occlusive disease. D, right lower extremity angiography with possible intervention. And we chose this, but E is diagnostic right lower extremity angiogram followed by FIM to below knee popliteal artery bypass with saphenous vein. I think if the patient is more healthier, we'll go with this according to the trial.
Yeah.
But question, doctor.
Yeah.
In this patient, we know that he's thrombosed and his symptoms are a bit acute, like 2 weeks, and it's thrombosed over the artery. How to prevent this during the maneuver of the wire and the catheter that I'm not causing any distal embolization?
It is very simple. We talked about before. If you have a complete occlusions, like I have a complete SFA occlusions, and I put my wire go very easy, that means a clot there. Because when you have an occlusion, you have to struggle to get through it. So if you get very easy, people get happy. Oh, that's good. I crossed in 5 minutes. No, this is a very bad sign. So if you have a complete SFA occlusion or popliteal occlusion and you put your wire and go very quick and you cross it, then I use a Rotarex. Then I try to do some thrombolysis and use Rotarex to remove the clot before I do any intervention. Because this kind of patient, if you do intervention, as you said, you end with the embolization. And we saw that many times.
Yeah.
So again, the way when you have a complete occlusions, watch how your wire, how easy you cross it. The easier you cross it, be careful because that means it's underlying the clot. It's a stenosis, but there's a clot, the way we decide, And this is always back in my mind when I do that. Go ahead.
If I did this patient, the same patient, I did CT and it showed the stenosis and I'm questioning thrombus over that area. Should I start him on anticoagulation and wait a bit? Or should I start an anticoagulation and I take him with back of my mind that I may use thrombolysis and Rotarex during the surgery, during the angio?
You mean to admit him and put him on heparin? Or you talking about thrombolysis at TBA?
And no, I will start him with anticoagulation. Then I will take him because I need to fix whatever I have with the stenosis. But how to prevent the thrombus? I start with Rotarex على طول if I have CT showing thrombosed area.
I mean, CT will not show much. You can show an occlusion. It's really hard to tell how old is a clot, you know. It's acute.
Yes.
But some of the clot are old. Not all of them are acute. See what happened, they get a chronic clot, and then one of them will be acute. So you have mix, because these are chronic things. So they get occluded slowly, they get tolerated, occluded slowly, and then you have the last piece, which is really push them to the critical limb ischemia. So again, all depend on the wire. Sorry, I'm saying when the wire, like if you have total occlusion, if the wire go easy. But if I struggle, that means only small pieces will be fresh and the most will be chronic, then I will not worry. I will just balloon it. And what usually I do in this patient, I balloon in lower size. Like if patient is 5, I balloon with 4, just the top and trunk. And mostly I would like to do a primary stenting. If I feel the clot there, do primary stenting right away. I think it is better. You know? So all depends. But you can do thrombolysis, but thrombolysis will not work. With acute on chronic, they will not work, you know. And the second thing, this patient 74 metastatic lung cancer, I don't know if she has a mets to the brain also. You can have thrombolysis, get intracranial bleeding. Also is risky. So you have to do a head CT first, you know. So I think in this patient, the best way they get to the, you know, angio suite, do an angiogram, help her some, just relieve her symptoms, you know. You're not looking for perfect. Whatever you can open, easy, simples, and then put on anticoagulation. And also she's not very active, you know. So the more just out of the wrist pain will be fine. You don't want to get her back to normal.
Dr. Samer, even with local treatments, they angiojet local thrombolysis.
I mean, they will work, but again, it's not different treatment. Just to open that, still have to do intervention below or stenting. And so, if you're going to use an angiojet or whatever you know you're going to use, you can use it. But this is just to open a channel to just remove, because a disease below that. Remember that. So you're just removing some of the clot. But after that, you still have to do ballooning or stenting. You cannot just do angiojet like a normal artery and you're done with it. No. Because you have an underlying disease. And as I said before, some of the clot will be chronic, will not be removed by angiojet, you know. So you have to be careful.
Great, Doctor. Clear. Thank you.
All right, well, let's go to 20. We'll go back to Bassam.
Okay.
Okay.
Yeah, this I can't see the question. Yeah, now.
You cannot see it?
No, now I can see it. Yes.
Okay.
73 years old man with a history of diabetes and renal insufficiency. Has non-healing wounds of the left foot. The skin of the foot is atrophic with rubber. And there are gangrenous wounds of the first and second digits. He has palpable femoral pulses, but no palpable pulses distally on either limbs. Sorry. Non-invasive arterial testing reveals a left leg ankle brachial index of 1.4, which is unreliable due to heavy calcification, with moderate to severe blunting of pulse volume recording at the calf and ankle. Toe pressure index, which is more sensitive, more accurate, is 15. The most likely diagnosis is the picture is critical lower limb ischemia, but the ABI is unreliable. We take the toe pressure index or toe pressure. Yeah, it's more accurate when the ABI is non-reliable. So the most likely. Yeah, if the toe pressure is less than 30, then it goes with critical limb ischemia or severe atherosclerosis.
But the more this scenario, they want to tell you that, as you said, you already mentioned that ABI is high. That means patient has a calcified artery, correct?
Yes.
So they want to say. Okay, well, let's see what they said here.
The answers: normal arterial perfusion with neuropathic ulcer. No, it's not. Microembolic occlusion of digital vessels? No. Acute ischemic from popliteal artery thrombosis? Also no, because it's not acute ischemia, it's critical ischemia. Chronic limb-threatening ischemia with calcific arteriopathy. Yeah, I will choose this one. E, severe small vessel arteriopathy affecting digital. No. Okay, the answer is D.
Yeah.
Yeah, because heavy calcification.
I think the whole question is just to tell you that, you know, that if you find high EBI, don't mislead that is normal EBI. So as you said before, that means the artery is very calcified. So you have to go to EBI, which is done here. So again, it's a simple question, but it's the whole idea from this question. All right, let's go to keep going. We want to keep going, guys? We still have 10 minutes. Yeah, we can keep going. 21st.
Yes,
who is
please.
that? Ahmed? Let's say Ahmed. You're getting all difficult questions.
All right. 78-year-old woman with a history of coronary artery disease, congestive heart failure, and smoking. Presents with non-healing ulcer of left second toe and an ankle brachial index of 0.3, critical, on and the affected side. She is currently taking atenolol and furosemide. In addition to discussing revascularization to prevent limb loss, medical management include aspirin orally.
Let's say before you go there, so patient with a vascular disease. Okay, what is the recommendation now? Patient we want to treat him medically. So what usually we give now for patient when it comes to our clinic with a vascular disease? So the first thing we give them is aspirin and statin, right?
Sorry.
Two things, right? So, but now they give you a double of mixed things. Let's go one by one. See what
okay, they give aspirin only.
Yeah.
No, aspirin and a statin.
Okay.
Or aspirin,
Okay.
statin, and metoprolol. She's heart failure, I think, furosemide. Or aspirin and atorvastatin of 80 milligrams instead of 40.
Okay.
Or aspirin, metoprolol, and Plavix.
Okay. Well, I tell you, usually you have to give aspirin and statin. This is nobody argue about, you know. The problem is 40 or 80. Maybe the cardiac people, they know better because most of our studies all came from the cardiac people. So and you can correct me if I'm wrong, but I think the Heart Association, they recommend to give statin 80.
Yeah, I think so. It is mentioned in Rutherford, 80.
Rutherford, 80. So it has to be an 80 and aspirin. Dual antiplatelets, we do it in the clinic. The patient comes to us, we give them aspirin and Plavix, but really is no data to support that. It just, I think we took this from the cardiologists, they do that. So, but really is no data to support that aspirin and Plavix is better than aspirin alone. But the two most important to give statin 80 milligram and aspirin. This is where we have a hard evidence that will help patient with vascular occlusion. Okay. So my answer will be aspirin and statin 8 milligram. Okay. Muhammad, do you want to add something from the cardiac standpoint? Guys, you do the same?
Actually, we do not. I did not see any patient who received this much or this big dose of 80 milligram of atorvastatin. Usually it is 40, and sometimes if the patient weight is lower than 50 kg, usually we give 20 milligram. But of course, I'm here to learn from you and your experience.
It's data is not, let's see here. They said current guideline of American College of Cardiology, high density statin, 80 milligram daily for patients with symptomatic peripheral disease, with an inverse dose response relationship seen with death and amputation rate. So they found amputation and death is lower if you give an 80. While there is evidence to support the use of antiplatelet agent, well, see, they have some evidence that Plavix instead of aspirin will help. Sometimes we see aspirin better, Plavix better than aspirin, but we don't have an evidence. And also no evidence that dual antiplatelet therapy is required. Even though we do that, but there's no evidence, you know. Beta blocker usually doesn't help unless if we want to do a surgery. Some data showed if you give them beta blocker before surgeries, they get better outcome. But also I think that the evidence is not very clear, you know. It's not recommended to initiate it prior to limb revascularization. I'm saying if you do surgery, then some people, they put in beta blocker because some data showed putting beta blocker, you decrease your mortality, you know. Other data, they came and they said, no, beta blocker really doesn't help even increase your mortality. So we're still confused. But dual antiplatelets, we don't have no proof. So the only thing we know that aspirin and statin is important. Usually I give 40, but this is the first time I see 80. But most probably this is from recommendation from the, you know, American College of Cardiology and American Heart Association. So we'll keep this one in our mind, okay? All right, let's go 22. Emma, do you want to do it?
Yes.
Okay, let's see what is that.
A 71-year-old man presents with disabling left leg claudication and failure to improve with medical management. His symptoms improved after an endovascular procedure on the same leg 3 years before, but his symptoms have recurred. He undergoes an angiogram with an intention to attempt revascularization. The lesion could not be crossed. He has no ipsilateral greater saphenous vein due to prior coronary artery bypass grafting, but has a good quality contralateral great saphenous vein. The next appropriate management would be.
All right, well, let's see what we have first, okay? Let's the profunda here. This SFA complete calcified and occluded. This SFA, you can see stent is occluded here. This popliteal, this SFA is open here. This is SFA. What is that here? This is a popliteal. I think this is an E here. So this is a popliteal here. And you have good runoff. You have 3 vessel runoff. So really, we have a good popliteal, good runoff, good profunda, good femorality. The only thing we have an occluded SFA. And they try endovascular first, it failed. They try again, it doesn't work. So you have to do a bypass. Why that? Because she has disabling. You see, they mentioned this one, disabling left leg claudication. Okay, and she failed to improve. So that means they're pushing us that we have to do something. Okay, so that means we want to do a bypass. So the question now, should we do it with the vein or should we with the prosthetics? To make it difficult, they said the ipsilateral vein is gone, but the contralateral vein is available. So the question now, should I go take the contralateral vein or do a prosthetic graft? I mean, this is difficult for you, Muhammad, but we know that it's an older study. They compare above the knee. Really, if you stay above the knee, there's no difference between prosthetic and vein graft and the patency. If you go below the knee, then is this. Then yes, you have to use a vein graft. It's much better than graft. So as far as you stay above the knee and you have a good runoff, I'm not saying a poor runoff, then the bypass with the prosthetic will be enough. You don't have to. So on this patient, I will not go to the legs. I'll leave it there. It's the lesions above the knee. So I'll just do a fem pop with a prosthetic. Simple like that. So anybody has a question or different opinion?
I have a question, doctor, if you allow me. Now there is an ipsilateral great saphenous vein that is already harvested. If we talk bilateral great saphenous vein harvest, whether that affect the patient, I mean drainage, I'm not sure. I don't have any clue about.
No, nothing to do with the arterial. No. So harvesting the vein will not have nothing at all at the, at the vascular circulations or outcome or claudication or progress of the disease. No, nothing to do with that.
I see.
Yeah. But if you don't have vein both sides, you need to do a vein. then what you do? They have to do like below the knee. Then you go to the arm vein. This is the second thing. Auto vein or cadaver vein, they don't work. They are very worse. I think the bypass is better. I mean, prosthetic is better than the homograft, you know, or allograft, because the patency is less than 1 year. So we don't use it, you know. So if you have no vein in both arms, you have to go below the knee and you have no veins. I would try the upper arm. If the upper arm's vein is bad, then you can still do FEMPOP below the knee with like prosthetic, but then I'll put the patient on warfarin. Then you have to put patient on anticoagulation to try to keep the, you know, the bypass open as much as you can. Okay?
Clear.
All right. Let's see what the options you have.
So A, femoral to above knee popliteal bypass with contralateral great saphenous vein.
This one is not wrong. You can do. Let me see what he asking exactly. They said the next appropriate management, appropriate, but doesn't mean it's not wrong. I mean, if somebody took a vein and did bypass with a vein, it's not wrong. So you see, it's not the most appropriate, but it's not wrong. So you have to be careful. So I cannot say this is wrong. No, you can go take a vein, but it's not. Why need to take a vein if you have same patency with the graft? So not A. Let's go to the next one.
Femoral to below knee popliteal bypass with contralateral great saphenous vein.
We don't need to do below the knee because you can see here, this is the knee here, and popliteal is here above the knee is fine. So I have to go below the knee because we know that the moment the bypass crosses the knee, the patency rate goes down significantly. So try to stay above the knee as much as you can, you know? So we don't have to go below the knee in this patient. So we don't need that. Okay?
Okay. C, femoral to above knee popliteal bypass with prosthetic graft.
Okay. Next,
So,
we talk about it. Most of it be the right answer. But let's see what the answers say.
Femoral to below knee popliteal bypass with prosthetic and a distal anastomotic adjunct.
So what happened is that, again, we don't have to go below the knee. But what they try to tell you here that if you have to go below the knee, I said, like I give a scenario that both veins are not available and you have to go below the knee with a prosthetic graft. One of the things we do at the distal anastomosis, because most problems come from distal anastomosis. You see, when you do a bypass, all the time, 90% your problem is a distal. Rarely you see problem at the proximal. So then it's anastomosis, you know. So what happened, the graft is very rigid. The reason why we get a stenosis, and the artery is very flexible. The reason why we get a stenosis, especially the artery is small and you cross the knee. The reason why they put a patch. So what happened, we cut in a beveled fashion the graft. So half of the anastomosis will be graft and half of the anastomosis will be a vein. Or we do a Miller cuff, you know, with a vein distal. So we try to do just a distal anastomosis with the vein, any piece of the vein, just to decrease the chance of stenosis and thrombosis. That's what they mean by distal anastomosis adjuvant. Yeah. Next one.
E is to continue medical management.
No, I think because she has a disabling, right? Let me see what they said here.
Yes.
Yeah, disabling left leg. So you have to do something. You can't leave her like that. Okay. So I think the best way with this one to do FEMPOP. So what we want to tell you, and this is what we usually do. For above the knee, always we feel comfortable with that prosthetic. You don't have to bother. Unless the patient has a good vein, then bypass. And remember, the vein is better than the graft only if the vein is good quality. If you have bad quality vein, then still the prosthetic graft is better than the vein, you know. Sure. So, and this is different from the cardiac because cardiac, they have the legacy to cut pieces, you see. The heart, the saphenous vein, they harvest the vein, this middle part is damaged, it's okay because they just need the pieces. So in the heart is not a problem, but for us, we want the whole vein to be good. Any small pieces area is damaged, it may ruin away all your anastomosis, you know, or your surgery. So this is different from the cardiac surgery, you know. So you need a good vein. So if you don't have a good vein, no, I still feel the graft is much better. All right, guys, I think we're done with 1 hour, so it's good, 22. So next time we'll start with 23. Any question before we leave? If anything we talk about it today?
Dr. Samer, في بس عندي سؤال. I need to know about venous arterialization as an option.
No. No. Venous arterialization is the last of your options. We have no graft, no bypass, no prosthetics, no outflow, called a desert foot. If you have a desert foot, like you do an angiogram and no outflow to the foot, this is the only time you can do venous arterialization. But if you have a single artery, like a long time ago, before this angioplasty, we used to go down all the way to the posterior tibial arch and do anastomosis, you know. So the vein is just a small option to a bypass for the vein. So if you have a good vein, you can go really very, very distal. So the venous arterialization only in like desperate situation, which has a tissue loss, he's going to lose his leg with amputations, and you have no outflow, then you try that. But if you have any outflow, any distal artery open, always bypass is
Okay.
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 All right, guys. Any other question? All right, we'll meet next week. Take care, guys. Good night.
Thank you so much.
Bye-bye.
Thank you. Thank you very much. Thank you.